Oh, thank you very much. I'm going to do the same thing. So here we go. Much more comfortable this way. All right. It's really a pleasure to be invited here. This is, I sometimes feel like my home out west, because when I came from New York and they said, "What are you doing looking up at the sky all the time?" And I said, "I haven't seen blue sky for 4 years." And so I felt a little bit like the pioneers. This is the place, and it's always a pleasure to come back, enjoy the environment, and I'll give a little historical perspective. Dr. Beals invited me one time here to talk to a group of patients, and I think there was about 10 or 12 that showed up. So what a difference 15 or 20 years makes. But anyway, I just want to share some vignettes, and as Dr. Robinson said, this is somewhat highly technical, and I don't necessarily expect you to have the background to understand it in terms of the biochemistry, but I think you can get the feel of why this is important and why we're studying these sorts of things, to understand not just your symptoms, but to understand what's causing them, what's motivating or directing those symptoms to be developed, and then perhaps then we can have a better understanding of how we're going to treat it. I also want to make the point that the things I'm talking about don't necessarily apply to all of the patients with chronic fatigue syndrome, and that we're really looking at subsets of the disease that may be more useful. Now, as you know, this particular disease has been the illness of many names in addition to many faces. In Europe, it's still called myalgic encephalomyelitis, and that's because of their emphasis on the cognitive dysfunction and the brain dysfunction. In Japan, it's called low natural killer cell syndrome because of the predominant immunological finding of low natural killer cell function. And natural killer cells are these lymphocytes that are a very primitive part of the immune system. Sharks have only natural killer cells, and they survey for viruses and for cancer cells. Yuppie flu was the thing we got stuck with here because of the perception that it was wealthy, middle-aged females who had nothing better to do than to complain of fatigue. Some professionals have chosen to label it chronic fatigue immune dysfunction syndrome, again emphasizing the immune dysfunction, but not all of the patients have immune dysfunction, so that particular term has come into disfavor, and we're back with chronic fatigue syndrome. I don't want to get into all the debates about what the name should be and what the name shouldn't be and all those kinds of things, because to me as a clinician it really doesn't matter. I know what I'm seeing, I know what I'm treating, I don't know enough about it. I understand for you patients that can be a huge issue because it's demeaning. The very term chronic fatigue, everybody's tired. Doesn't say much, doesn't communicate much, and can be taken very lightly. The problem with changing the name, I think, is that what are you going to change it to? What's better? What's more helpful? What's more useful? What communicates better? Well, as you know, there's been recorded outbreaks of chronic fatigue around the world for a long time. I got involved with this in Incline Village when suddenly a number of patients of mine became acutely ill with a viral-like syndrome. Upper respiratory complaints, dizziness, headaches, malaise, lymph node swelling, etc. That's ancient history now, but it does bring an interesting research point because it's easier to study cluster epidemics. All the people get sick at the same time. They may have similar findings. They may have similar environmental factors. And so we still look for clusters in order to study the disease rather than the sporadic form which are located here or there. Some of these descriptions have been more extensive than others. In Iceland, they've studied these patients now for greater than 50 years. And so they know what happens to people who've been sick for 50 years. The same thing with the Punta Gorda, Florida outbreak, in which those patients have been followed for a long time. I put up this slide to say this is not unique to here. This is not some yuppie thing that's isolated to the United States. It's been reported in every country that follows diseases: New Zealand, Australia, Italy, the Middle East. We don't see it from the third and fourth world countries because they're in survival mode. They're not certainly looking for this type of disease process, but I have no reason to suspect that it wouldn't exist there. Now, national attention came because of these outbreaks, and here's, a Newsweek saying, chronic fatigue syndrome, disabling disease, affecting millions, still a mystery. And you can remember this era when the lay press actually controlled the disease. And it would be on the news, and there was this whole thing about being afraid. People didn't want to go to school with my children because they were afraid of catching something. A little indirect logic there, but things like that. And we certainly sort of passed through that era, although I think actually that emphasis by the lay press was helpful in bringing national attention and getting things studied. Well, there's a number of myths around chronic fatigue syndrome that I wanted to address here, and some of this you probably already know and some of you may not. But the first is that it's a relatively rare disorder. Well, the fact is that the prevalence is about 70 to 200,000, depends on how you count and what definition you use, and Dr. Jason yesterday gave us a nice presentation on that. But let's just say that that yields about 500,000 people in the United States with chronic fatigue syndrome. Much, much more than multiple sclerosis, for example, that we all know and take very seriously. So the number of people affected in Utah by a conservative definition then would be about 4,000 people. Probably more. What is the annual economic loss? At least $1 billion a year. At least a day of Iraq is lost in the United States with disability, medical payments, loss of income, all of those factors. This is a very rough estimate that we did for one of our grants in order to demonstrate to the powers that be that this is not an insignificant, trivial problem. Well, if you look at the economics within the United States, the market potential for a diagnostic test, and I'm working with Abbott Laboratories and some other laboratories about this, would be if everybody who came to an office for fatigue had the test, if there were a test, for chronic fatigue syndrome, the market for that alone would be $120 million a year. So the laboratories are becoming very interested in this now. The market potential for an effective therapy is estimated to be about $250 million per year if you only treated 5% of the patients. If you said this drug works for 5% of the patients, and so you began treatment. So you can see we're starting to evolve into this economic model that the United States follows for most of the things we do that says, well, can money be made off of it? Because if it can be, then we're probably interested in it. So it took me a long time to realize that that's how we had to evolve in order to actually help you, the patient. So there are some numbers that are just thrown out. Very conservative estimates. Again, based on just one test per year for people who complained of fatigue. Well, it is difficult to know what definition to use. Where are we, this is my favorite cartoon, right? Because I feel like this all the time. I typed in the description of your symptoms and the computer says you have Dutch elm disease. Well, I don't feel quite as much that way now as I did 20 years ago, but there's still parts of that are true. And I'm sure you patients feel the same way. You flounder around, you look on the internet, you look for sources of information, et cetera, et cetera. But organizations like OFFA are certainly doing a lot to sort of turn those things around. I really have always used this philosophical approach. It's only with the heart that one sees rightly, for what is essential is invisible to the eyes. And that is so true with this disease. How many times have you been told you look great? Oh, I'm so sorry to hear you're sick, but you look so great. And many of the things that have been documented to be abnormal in chronic fatigue syndrome were not immediately obvious. And so when primary care docs would do a thyroid panel, it would be normal. They do a glucose, it would be normal. The CBC would be normal. The chemistry panel would be normal. So they led them to the conclusion, well, there's nothing wrong with these people, or, I think I know a good psychiatrist, or see you in 3 years, I'm sorry you're sick, that sort of thing. But it's the patients that taught me about this. The repetitive stories, the same things. Why are they saying this?
And in my particular case, I had the advantage because I had people who were perfectly well and suddenly became perfectly sick, and they were very disabled. So I used to say, nothing will convince me that they suddenly had an epidemic of craziness, although that was alleged. The second myth is that the highest prevalence is among young, affluent, white professionals. Well, there's several reasons for that. That's the group of people who complained early on. Their money was taken from them, their position was taken from them, their lives were taken from them, the tennis games were taken from them, whatever it was. They complained loudly. They found their ways to physicians like myself. So the initial description actually was somewhat consistent with that. But the real fact is that men, women, and children from all socioeconomic backgrounds can be affected by chronic fatigue syndrome. The gender fact, it is much more prevalent in women. And that's something we're studying. Why is that? It brings up the issues of possible hormonal or genetic or other factors that might play a role in that. I sometimes think this does a disservice to men with the illness, though, because men think, oh, I got a woman's disease. And it really drives them into the closet. They're very quiet about this, et cetera, et cetera. And they're relieved to know that while there's clearly more women affected, it's fairly prevalent in men as well. The racial issue. Dr. Jason presented evidence yesterday that actually the incidence is highest in Latinos, second in African Americans, and third in Caucasian. So that's a total myth. My personal belief about this is we're just not looking at those populations. They don't have quite the same vocabulary, they don't complain about the same things, they don't have the same access to the medical system, but it's not that the disease doesn't exist within those groups. I think probably the biggest overlooked population is the pediatric population. Many of us who deal with chronic fatigue syndrome are not pediatricians. We're uncomfortable with it. We have trouble with the definitions as it applies to adults. We have even more problems with it as it applies to children. And I think that's unfortunate because the children particularly have been understudied, and they pay a tremendous price in loss of their quality of life and educational process, etc. Here's an example of one of my young men who went doctor to doctor to doctor to doctor, and everybody says, oh, you're just crazy because you look perfectly well. And it really has long-term ramifications in these people with respect to their education, health identity, confusions, etc. The third myth is that chronic fatigue syndrome is just a form of depression. And I still hear that, even now in 2004. And in fact, chronic fatigue differs from depression in many, many ways. But a few of them are onset, incidence, symptoms, attributions, lab tests, responses to treatment, and in fact, rehabilitation. So while depression can certainly coexist, and you can certainly become depressed over your symptoms, that is not to say that depression is the cause of your illness. I'll come back to this slide later, but this is part of our R01 NIH grant in which we asked the question if we could differentiate chronic fatigue patients from depressed and from controls. And really, much to my amazement, the separation is nearly 100%. You see, by multivariate analysis, whereas we took everything we studied, we put it in one pot, and we said to the computer, can you differentiate these groups for us? And you'll see the chronic fatigue patients on the right, a very, very clear distinction from normals, controls who are in the red, and depressed who are in the green. And you can also see that you can make a differentiation between the controls and the depressed as well, but that wasn't our purpose. I point this out because only one patient was miscategorized by this technique as being a control. So, of course, the symptoms are very common, and you can see where this sort of thing came from. I mean, you could read down this and say, oh yeah, a lot of these symptoms are exactly the same as one finds in depression. And so, way back, and I'll take you back in history here, eventually the CDC said, well, we really need a definition for this. So in 1988, they established criteria for chronic fatigue syndrome, which was very helpful, except that it was a research definition. And as you recall, many people were excluded, particularly people with comorbid psychiatric problems, people who didn't have acute onset. There were lots of problems with that definition, and that's why it ultimately got revised in 1994 and was published as the Fukuda criteria. And those are the criteria we live with today in the United States. And probably all of you who have been appropriately diagnosed should meet those criteria. But there's very distinct problems with those criteria that defy research methodology, etc. The way it's structured, it was a compromised definition. And so, as a result, it does not identify a homogeneous group of patients. If you talk to your neighbor here today, you will not have the same symptoms and the same disease that your neighbor does. And that's the problem with this definition, particularly when we apply it to things like research and treatments. Because maybe you have one cause of your disease and your neighbor has another one. I treat you both with the same drug. You respond, your neighbor doesn't. The FDA says it's a worthless therapy. And that's the problem with heterogeneous definitions. So, what we who are involved in research have done, as we've said, we've got to get better definitions, and we have to look at subsets. We have to look at people who look like each other. Like maybe I'm looking at one specific thing that I'm going to come to a little bit later, and I say there's 25 people in this room that have that abnormality. So I'm going to look at that abnormality, and I'm going to see what I can do about that, what I can understand about it, why it's happening, what I can do about it. Now, that technique is criticized because you other 300 say, well, what about me? But I promise you it's the only way that we'll ever really solve this disease and really move on to where we should be. Because you're not all going to have the conclusion that everybody who researches this disease has come to is there's not one thing that you all have that can be treated that would make you well. We probably would have discovered that by this time. So, a couple years ago, the Canadian government took it upon themselves to make a better definition for chronic fatigue syndrome that's usable by the patients, usable by primary care physicians. And I'll go into this in some detail later because I think it's really, really helpful, and I think you patients should become aware of it. It's gaining acceptance in the United States as well. Well, possible causes of chronic fatigue syndrome, you probably all know this, so I'll go over it quickly, have been infectious agents have been implicated, and indeed some people have documented history of an acute viral illness from which they never recovered. The immune system has been implicated as a big part of the problem. The hypothalamus pituitary, the neuroendocrine, neurally mediated hypotension, nutritional deficits. There's been a lot of theories out there, and they're actually not just theories. There's usually support for these assumptions. Most of the researchers in chronic fatigue syndrome agree generally with the model that I'm going to propose here, which isn't mine, but I happen to be one of the people that generally agree with it. And what it says is you probably have a genetic predisposition to develop this disorder. And that's not unusual. There's genetic predisposition to diabetes, to breast cancer, to a lot of the diseases we deal with in internal medicine. There are nice twin studies going on to look at this, with identical twins where one twin has chronic fatigue, the other twin does not. That should yield us some very, very interesting information with respect to genetic predisposition. Environmental factors have always come up. You know, especially when there's a cluster. Was there something in the environment of this that precipitated this and that was more toxic than another? You're probably all familiar with the leukemia cluster in Fallon, Nevada, where there's 19 children with leukemia. It's almost certainly environmental. That isn't genetic. They didn't have, weird parents that happened to all settle in Fallon. So, but it's harder than it sounds to look at and to really identify those factors. You know, there have been research into high tension wires and all kinds of things. We live in a dirty environment, and so these are hard things to sort out. Stresses and chemical exposures. We've all heard the cases of chronic fatigue that happen after trauma, after surgery, after an automobile accident, etc. Personal stress, divorce, things like that. Clearly, they have some impact here. And they result probably in immune dysregulation. Immune dysregulation then would set you up for opportunistic infections, bacterial, viral, fungal, parasitic. These may be simply the trigger. Frequently find that the initial infection came and went, but left its mark on you in terms of dysfunction. You don't work right after that infection. Result in these symptoms that are called different things by different people, largely depending on what part of the disease they're looking at: multiple chemical sensitivity, chronic fatigue syndrome, multiple allergies, etc. Now I want to look very specifically at something that I've been interested in for many, many years. Because of the viral nature of the patients who got sick at Tahoe, I thought, well, if they did have some virus that we haven't identified, maybe I can find something abnormal in their immune system. And where I chose to look was at the antiviral pathway. The antiviral pathway has been described for many, many, many years in a number of models, in cancer, in infectious diseases, in HIV, etc. It's well characterized. We know a lot about it. The problem is it's very, very complex. So most physicians don't know very much about it, and patients obviously know even less. And I'm just a beginner in my knowledge of this pathway. But I wanted to outline it here for you so you can again see the strategical approach that we're taking to your illness. Now, the antiviral pathway is the way that mammalian cells, and we're mammals, fight viruses. And this is a very clever system that has a regulatory system. It's turned on by an insult. It can also be turned on by viruses and cytokines and a number of things. And it's a cascade. It's an enzyme cascade. And the point I want to make here is it requires ATP. It requires energy to run it. Okay? And ultimately, you get elevation of 2,5-A synthetase, elevation of RNase L, and RNase L is the culprit. RNase L goes and kills viruses and prevents viruses from replicating. So just keep that in mind as we go through these next few slides here. The findings in chronic fatigue syndrome that have been reported by a number of researchers in France, in Belgium, in Sweden, and in the United States is that the 2,5-A synthetase is activated, it's upregulated, that the bioactive 2,5-A is present, and that RNase L is activated as well. So it's as though this immune system is stuck on, which leads one to the conclusion it's either running inappropriately, like patients with allergies where their B cells are excessively turned on, or there's some agent that you're trying to kill that's not being killed. So that was the question we proposed. We had a large study here that looked at a number of things: blood chemistries, blood counts, functional status, immune function, and that's the summary slide I showed you earlier, put all these variables into one database. Now, this particular study we did over time. We did it 18 months apart. We did 2 blood draws at baseline, 2 18 months later, because the allegation was, well, maybe this stuff changes. Maybe these people, just had a bad day, and so their immune dysfunction was present on one day and wasn't present the next. So we wanted to correct for that, so we went back and we split it by 18 months. We took control groups that had nothing to do with patients. These weren't wives or kids or co-workers or things like that, because we wanted a really clean control group, and we took as depressed controls depressed patients who were not treated pharmacologically. So there was not the role of the antidepressants in this particular study. Immune function, again, that we measured was natural killer cell function, both the numbers and the function. Cytokines, because that's felt to be an intermediary, and there's been some theories that elevated cytokines may produce some of the symptoms. If you take interferon for hepatitis C, you get very sick. the entire time that you're taking it with flu-like symptoms. So some of the researchers have said, well, maybe elevated cytokines play a role here. And then we looked at the antiviral pathway, particularly the 37 kilodalton fragment, because that's an abnormality of RNA cell that to date has only been described in two disease subsets, in multiple sclerosis and chronic fatigue syndrome. It's not been described in rheumatoid arthritis, in HIV, and in other places that it's been looked at. We had a fairly large number of patients in here. They met the CDC criteria, et cetera. And I just want to underscore a few of the results, and because they're very interesting to me. The functional status was able to differentiate patients from controls from depressed by the SF-36. And most of you patients here have probably taken the SF-36 at some point in time because it's quick, it's easy, it's scored by a computer, and it tells me a lot about how you're functioning. It can be used over time. And the point I want to make here is a couple of things. That if you look at the vitality score, for example, chronic fatigue patients are near the bottom. There's no... Depressed patients have some impairment of vitality as well, as you can see, but not nearly to the extent of chronic fatigue patients. Look at role limitation caused by physical disability. It's near the cellar. It's near zero, versus depressed patients who have only a 20% impairment in their role functioning versus controls. And the most interesting thing that was not predicted when we structured this particular study, and we got consultants to help us with this, that you could not distinguish chronic fatigue patients from depressed and controls based on the mental perceptions, the last two scales. They're the same. So you're no more mentally unstable than the general population and depressed patients. So we now use this in another way. I use this as a screening tool because patients who really truly have chronic fatigue syndrome should match that bottom line more than they match those other two lines. But what it really means is that you're significantly impaired. Very, very impaired in your overall function, not so impaired in your mental health. The results of the immune function was interesting. And we really had been repeating work that had been done previously, but we used bigger control groups. And we found that natural killer cell function was indeed decreased, that interferon alpha was elevated, that RNase L was markedly elevated, and there was the presence of this unique 37 kilodalton protein that in the literature is called the low molecular weight protein. And when you look at it graphically, you can see the gross differences in function of natural killer cells. Now, the natural killer cell line is higher because this measures how many natural killer cells it takes to kill a target. So the more it takes, the less well it's working. So on one variable alone, we could differentiate patients from controls. When we used all of the immune markers and put them into one pot and said, okay, if you take this panel and you try to differentiate, the differences become even larger. And you can see the immune panel does not differentiate depression from controls, but it does differentiate depression from chronic fatigue and controls from chronic fatigue. The big question, of course, becomes, well, what about other populations of patients? What about diabetics? What about this? What about that? And obviously, more work needs to be done in that. The laboratories got wind of this result, and they've now packaged this type of immune into a chronic fatigue panel that can be ordered. And this is a test that can be done on you, and you'll know if you are deficient in those particular parameters. Again, I go back to this canonical separation, which is really the summary. And in this slide, we put everything in there. We put the blood chemistries in there, the histories, the exposures, how long you'd been sick, everything. 300 variables. We stirred the pot and we said, can we identify chronic fatigue patients? And yes, we could. So in summary, chronic fatigue can be distinguished from major depression based on abnormalities of the immune system, a greater and a different functional impairment than depressed patients have. Now I want to talk about another subset, and this is HHV6. And I simply point this out because this is what I'm talking about. Perhaps there's some of you in here who suffer from something like this that can be separated out, can be diagnosed, and can be treated. And you can leave the rest of the world of chronic fatigue behind you. Why am I interested in HHV6? Because we identified it in a number of the patients in the Tahoe epidemic of 20 years ago. It's diagnosable and it's treatable. It is not to imply that it's the cause of chronic fatigue or that you all have it, but I would predict that some of you would. What is HHV6? Most patients have never even heard of it. What's its role in chronic fatigue syndrome? I'll go over that with particular emphasis on HHV6 in the spinal fluid. HHV6 is a herpes virus. You're all familiar with herpes simplex. You know herpes zoster, the cause of chickenpox and shingles. You've probably heard of CMV. You all know about Epstein-Barr virus. HHV6 was the sixth herpes virus described, so it got the next number. It was originally felt to be B-cell tropic, and so it was called HBLV initially in the literature. It's the cause of exanthema subitum in children. It's a rash. Children get it, they get well. But it may play a bigger role. We certainly know it can be found in saliva and PBMCs of healthy people. It can also be reactivated. It's kept in check by a normal immune system, just like herpes zoster is, herpes simplex is. Reactivation has now been reported in multiple sclerosis, in HIV, and in transplant patients. There's some exciting work from University of California, San Francisco, in which Dr. Ganane injected marmosets with HHV6 and was able to produce multiple sclerosis. So this is a very hot topic right now amongst virologists. Well, we found that there's two variants of HHV6, variant A and B. And B is most common. It's the one that children get that causes the rash and a minor flu-like illness. It tends to persist in the periphery. It's very, very common. We've all been exposed to it. 100% of people here would have antibodies to HHV6, variant B. Variant A, however, is more recently discovered and in fact probably should have been numbered a different number because it's quite unrelated to B. It's more neurotropic. It tends to be found in the spinal fluid. It tends to cause neurological symptoms, headache, concentration difficulties, brain fog, all of those kinds of symptoms. It's much more virulent. It's much more cytotoxic. A word of caution here, most laboratories still don't differentiate 6A from 6B. It's a critical point. Well, what might the role of HHV6 be in chronic fatigue syndrome? Well, we studied a number of patients with a whole bunch of pathogens, and I'm simply going to give you the information about HHV6. We look for rickettsia, we look for babesia, we look mycoplasma, all those things, but I'm just focusing on HHV6. Of 371 patients, 104, 28% were positive for HHV6 by certain techniques, which I'll come to. And of those, 25% were positive in the blood, but many, many more were positive in the spinal fluid, which is the sort of interesting part about this. Just recently, we've been doing speciations, and most of the specimens are positive for HHV6A, not for 6B. In the spinal fluid, we also did blood at the same time, and the difficulty with this is a number of patients were positive only in their spinal fluid and not in the blood. So you can't really use the blood test to screen for HHV6 variant A, if that's what you're really concerned about. Well, what are the results of these 145 spinal taps? 29 were positive, a very, very large number. We actually expected that to be maybe one or two, that this was really rare, that this rarely happened. But actually 20% of these patients were positive. One for EB, one for CMV, 27 for HHV6. And the important part here is they were all variant A. They were all the variant that we know attacks the central nervous system. So patients may be suffering from HHV6 even when the blood is negative. That's been reported elsewhere. It really makes diagnosis somewhat difficult. What is the rationale for studies of immune modulatory therapy? Well, the natural conclusion is that if you have dysfunction of your immune system, maybe fixing your immune system might make you feel better. It's really sort of a basic premise here. And we had plenty to look at: low natural killer cell function, upregulated RNA cell pathway, this abnormal 37 kilodalton protein, evidence of viral reactivation. There are lots of reasons to look at immune regulatory agents in chronic fatigue syndrome, at least in the subset that demonstrates the immune abnormalities. And again, I want to underscore the importance of that. If somebody does not have immune dysfunction, they would not be a good candidate for immune regulatory therapy. So one of the first things we did was transfer factor, and that was because patients told me they were taking transfer factor from their health food store and feeling better. And transfer factor is produced in animals after they've been inoculated with a certain virus. So it's an oral vaccine of sorts that stimulates your immune system to fight certain agents. And it's available for HHV6. I thought, well, perhaps we should do this. There's been a large double-blind study performed now involving 120 patients at 3 sites, and the results of that aren't available yet. But we measured the same things that I've led you to understand: the immune system, the HHV6, and the quality of life, the Karnofsky, the ADL, the SF36, etc. That will be very interesting because theoretically it may make a difference. And it's very cheap and very readily available. You could go to your local health store and buy it. Now, we also treated patients with antiviral therapy if they fulfilled the criteria, if their spinal fluid was positive for HHV6 variant A. And this is the interesting part. Of 11 patients who have been treated today with IV therapy, 8 have had significant clinical improvement and 4 have returned to work, which in my experience is really kind of unusual in chronic fatigue syndrome, with one therapy over a 12-week period of time. But again, I caution you that this is a subset that followed a very strict protocol that had this herpes virus growing from their brain. So a lot of other people say, well, they didn't have chronic fatigue. What they had is HHV6 disease. Well, maybe that's true, but that's what we have to tease out from this huge population of people with all the different symptoms. Today you'll hear about primary sleep disorders. You'll hear about dopamine receptors. You'll hear a bunch of other things that may be driving your illness. And I simply present this to you as one of the subsets that we should be looking for because it's treatable and people get well and they return to work. Now, I caution you about conditions that mimic chronic fatigue syndrome, and I hope none of you here are self-diagnosed, because that's very dangerous and leads one into great trouble, particularly when you're trying to get your disability benefits and you say, I read on the internet and I got all these symptoms. There's many, many things that can mimic chronic fatigue syndrome. You are probably all aware of this. Even medications. People come on polypharmacy. They come on 39 drugs, and I take them off 37 of them and their fatigue goes away. Multiple sclerosis, bipolar disorders. We're starting to recognize bipolar disorders better, and which is generally associated with fatigue. And then the flip side isn't true manic disorder, but it's agitation and irritability. And the psychiatrists have taught me a lot about this. Well, what is the prognosis overall? You probably know that most people are going to recover in 2 years. This is CDC statistics. After 5 years, the recovery rate is only 10 to 15%. But that's based on studies that looked for return to work, not on symptom improvement, on functional improvement, on adjusting to your disability. And I have many, many patients that say, I'm 80% of what I was. It's okay. I still have a lot of symptoms, but I'm functioning okay. So these kind of prognostic numbers, you have to interpret very, very carefully. Also, a lot of these original studies were done without the benefit of any treatment. They simply followed people who had the diagnosis of chronic fatigue over 5 and 10 years. I want to talk just a little bit about disability. The fact is that about 60 or 80%, depends on how you measure this, of people with chronic fatigue are unable to work. but only 20% are currently receiving benefits. There's something wrong there. You'll hear a lot about that today from the attorneys, et cetera, why that is, what we might be able to do to fix that, and as a safety net. Disability is the last resort, but sometimes it makes a difference between you surviving and not surviving. There's a couple things I do to help in disability that other physicians don't do. The Social Security guidelines say you have to have some objective findings. So if you have an abnormal MRI scan that demonstrates these unidentified bright objects, that's one of them. SPECT scans are abnormal. SPECT scans demonstrate regional hypoperfusion, underperfusion, areas of your brain that aren't getting enough blood supply. It's a different pattern that's seen in depression, so I can sometimes kill two birds with one stone here because the pattern is not that one sees from depression. So when you're up in front of the disability judge and the opposite side says, this is just depression, you could say, no, the SPECT scan does not show that. The SPECT scan shows an organicity to this. Now, with respect to treatment still is very, very symptomatically driven. And what I generally do is I take the most severe disabling symptom, or the one that I think is most important, and I hit that very rigorously first. And oftentimes I do determine that. I say, what's disabling you? The fatigue, the lack of sleep, the brain fog. Many of my patients say it's the cognitive. That's really why they can't work. So I attempt to address that. We have a number of symptomatic therapies. Most of them are off-label, so we have trouble with reimbursement sometimes, but they can be very effective. There are very, very few FDA-approved clinical trials in chronic fatigue. One today that's in phase 3. So there's a long way to go. And as you know, in order to really utilize an agent and be reimbursed for it, it has to be indicated and has to be approved by the FDA. The FDA looks at efficacy and safety. They're frequently more concerned about safety than they are efficacy, however. Some of the things that are in the pipeline here are immune regulatory agents, antiviral agents, and drugs that specifically reduce fatigue. And some of those are out and available now. I use an algorithm for determining who I'm going to treat with antiviral therapy. And I'm just showing you this as an illustration. The patients meet the CDC criteria. They have prominent CNS complaints. They have an abnormal MRI and SPECT scan. They have an abnormal cerebral spinal fluid with elevated opening pressure, elevated total protein, and a positive viral culture. Then I'll treat those with antiviral therapy.